All right. Let's talk about a condition you're definitely going to come across in practice, especially in oral medicine and prosthodontics, and that's oral lichen planus, or OLP. Now, at first glance, lichen planus seems pretty straightforward. Like you see white striae on the buccal mucosa, maybe some soreness here and there, and you just move on. But honestly, the more you like dive into it, the more you realize how clinically layered and diagnostically tricky this condition actually is. So let's start from the beginning. Lichen planus is a chronic inflammatory mucocutaneous disorder, and while it can involve the skin, scalp, nails, and genital mucosa, our concern today is mainly the oral part. The cause isn't completely understood, but we know it's immune mediated. Specifically, it's driven by T cell mediated cytotoxicity that targets basal keratinocytes in the oral epithelium. Now, what actually triggers that immune response? Well, it's not always clear. Some cases are linked to systemic medications, others to dental materials like amalgam. There's also a known link in some populations with hepatitis C. And stress, stress seems to be a big aggravating factor for a lot of patients, but a lot of times there's no obvious trigger at all. Now, oral lichen planus doesn't just show up in one form. In fact, there are multiple clinical types, and a lot of patients actually present with more than one at the same time. The most common one is the reticular type. That's where you get those classic Wickham striae, those fine white lace-like lines you usually see on the buccal mucosa, often on both sides. These patients are usually asymptomatic, like they don't even know it's there. You just notice it during a regular exam. But then there's the erosive form, and that one's a lot more serious. You get painful, red, eroded areas, often ulcerated, and usually still surrounded by some white striae. It's very symptomatic and can easily get mistaken for like aphthous ulcers or pemphigoid or even candidiasis. And yeah, this erosive type, along with the atrophic form, carries the highest risk of malignant transformation. We'll get into that part in a sec. There's also a plaque-like form, like which shows up as flat white patches, often on the tongue, and that can look really similar to leukoplakia. Then there's the atrophic form, which shows up on the gingiva as diffuse redness, and that's easily confused with desquamative gingivitis, especially if there's no ulceration. And something super important to remember, oral lichen planus is usually bilateral and symmetrical. Like if it's on the left buccal mucosa, you'll probably see it on the right too. That's a big diagnostic clue. In contrast, oral lichenoid reactions, like those caused by drugs or dental materials, tend to be more unilateral or localized. So, how do you diagnose it? Well, first off, clinical appearance can give you a strong suspicion, but that's not enough. You usually need a biopsy, especially if it's erosive or symptomatic, or if you're planning to monitor the lesion over time. The biopsy helps you rule out dysplasia or carcinoma in situ. And then sometimes you'll need direct immunofluorescence testing to rule out other conditions like lupus or mucous membrane pemphigoid. In OLP, diff typically shows fibrinogen in a kind of shaggy linear pattern at the basement membrane, but we won't go too deep into that today. Now let's talk about malignancy risk, because this is where things get real. So oral lichen planus is considered a potentially malignant disorder. The overall risk is low, somewhere around zero point 0.5 to 2 cent, but it's definitely not zero. Malignant transformation usually happens in the erosive or atrophic forms, and it's most often on the lateral tongue or buccal mucosa. One thing a lot of people miss, transformation can still happen even if previous biopsies didn't show dysplasia. So yeah, long-term follow-up is important. All right, moving on to management. If the lesion is reticular and asymptomatic, you usually don't need to treat it, but you do need to educate the patient, monitor it over time, and make sure their oral hygiene is solid. Also, you want to ask about things like tobacco use, alcohol, stress, and help them reduce those if you can. But for symptomatic lesions, especially the erosive and atrophic ones, you've got to intervene. First-line treatment is topical corticosteroids, usually something like clobetasol propionate 0.05% in an adhesive base. Now, if that doesn't work, or if the lesions are widespread, you might need systemic steroids. And if it's still not responding, then calcineurin inhibitors like tacrolimus are sometimes used. Just keep in mind you've got to monitor for side effects, especially secondary infections like candidiasis. Oh, And yeah, speaking of that, secondary candidiasis is really common in patients using topical steroids long term. So always be on the lookout for that and treat it if you see it. In rare, stubborn cases, you might even need systemic immunosuppressants or to refer the patient to dermatology for co management. And don't forget to think beyond the mouth. If your patient has oral lesions and they're also telling you about itchy rashes, or if you see like those violaceous papules on the wrists or shins, that could mean systemic lichen planus. And for female patients, genital involvement is actually pretty common, even if they don't mention it. Same with the scalp and nails. So yeah, if there's anything that looks systemic, refer them to dermatology. So um, yeah, that's a proper breakdown of oral lichen planus, not just how it looks, but how it behaves, what to look out for, how to manage it, and when to be extra cautious. It's one of those conditions that like looks simple at first, but demands way more clinical attention than you might expect. If this helped clear things up, go ahead and like the video and subscribe to Dental School for more academic content. No fluff, just the good stuff. I'll catch you in the next one.